intracranial aneurysm, you can see I put a question mark because the thing is, where do you start? So since this type of lecture is mostly intended for our younger colleagues, and there are several medical students in the colleagues, I thought that I would briefly discuss some well accepted general concepts. And then I will try to address some practical questions, primarily as it refers to the decision to treat an unruptured aneurysm. And then the question always comes up nowadays is if when you decide to treat, do you use endovascular techniques or surgical clipping? So um, intracranial aneurysms are very common. We used to say that based on MRI studies or population-based studies, about 2 to 3% of the general adult population has a brain aneurysm. There are some emerging data from Norway using more advanced MRI techniques, and also from China, actually suggesting that the incidence might be even higher. When we think about modifiable risk factors, I would say that there is no question that smoking and hypertension, and particularly the combination of the two, are very well established risk factors, primarily for the formation of aneurysms, but probably also for their growth and rupture. Then we have non-modifiable risk factors, such as a family history. And there is the question, is it only first degree relatives, or also second or third degree relatives with the history of intracranial aneurysm or worse subarachnoid hemorrhage, or whether or not that also increase the risk of having a brain aneurysm. Now, from a practical point of view, the problem is that we have a large portion of the healthy population that has a brain aneurysm, but most incidental aneurysms, the vast majority actually of unruptured incidental aneurysms, they never go on to rupture. And that makes the decision making particularly complex in terms of decided who should be treated. There was an excellent review in Nature Reviews by Ateman and Rinkel, and their conclusion was that if we uncritically, we say, let's repair every single aneurysm that we found, that will end up with an unacceptably risk of complications in patients who probably don't need the treatment of the aneurysm. At the same time, if we say, let's not treat, as it was done in the past, let's not treat any aneurysm that has never ruptured, then we will expose a small number of these patients to the definite risk of rupture with all the consequences. So the decision, once we find an aneurysm, it's actually fairly complex. So then it comes the question, when we find an unruptured aneurysm, what is the risk of rupture? And of course, there is a lot that has been written. And I will review some of that literature with a little bit of a personal twist, and in the sense what I've learned myself in the past 35 years taking care of these patients. So I like also to dispel some myths. One is that all unruptured aneurysms are equal. Well, that's not true, and that's not only because of different size, different location, but the point that I will try to bring home is that personally, and I'm not alone, other researcher feels the same way, but I feel that the risk of rupture of a brain aneurysm, it's it's closely related to how long that particular aneurysm has been there. And this has been confirmed or postulated over the years, this theory, by a variety of clinical observations, but also mathematical model. In other words, the risk of rupture of an unruptured aneurysm, it's not a linear function of time. Just a few examples. This is something very known to us. This is a patient that presented to one of our affiliated hospital with some retroorbital pain and a partial third nerve palsy. And you can see that the CT scan does not show any evidence of bleeding whatsoever. However, the scan does show, as expected, a small, fairly small posterior communicating artery aneurysm. The patient is transferred to our unit, and as the nurse was placing a fall in preparation for intervention, here she goes. She has a bleed. So this was definitely an unruptured aneurysm, but it was causing symptoms because, as we know, because of the anatomical relation, the compression of the third nerve can cause combination retroorbital pain and partial third nerve palsy. But the aneurysm is fairly small. And we know that the third nerve, it's very often we see gigantic aneurysms or even meningiomas in this region without a third nerve palsy. So the nerve is very sensitive to something that it's forming. It's small, but it's forming relatively rapidly. So my hypothesis is that these aneurysms, they form because there is an intrinsic weakness of the wall. And of course, in this anatomical location, sometimes we can catch them right before we rupture. In the other majority of locations, we capture only after the rupture. Because there are not such anatomical locations. And this was the aneurysm that was, you can see here, was successfully treated with endovascular coiling. Another example that brings home again the message here I'm trying to stress is that when I see a patient with an unruptured aneurysm, the first thing I ask is, say, how did you find out? And the patient answer, oh, because I got an MRI. I say, I know that, but why did you have that MRI? And I listen carefully to try to understand if there is any chance that those reasons which led to a diagnostic study in these patients that we see with the ruptured aneurysm, whether or not the aneurysm could have been the relatively rapid expansion and formation of the aneurysm could have been a source. This is another case that also presented to one of the affiliated hospitals. A 52 electrician went to the doctor because he couldn't even explain. He says, something is funny with my vision. They did an MRA. The MRA showed a very small anterior communicating artery aneurysm. And, this was in February. The aneurysm was very small. The doctor went on our site where it said that very small aneurysms often are very benign. And sure enough, 5 months later, he presented with a subarachnoid hemorrhage. So this actually was a symptomatic aneurysm. It's a small, very small anterior communicating artery aneurysm, but it's pointing inferiorly. So the aneurysm it's actually was embedded into the optic chiasm. So I suggest that the aneurysm forms because there is an intrinsic weakness of the vessel wall, When the aneurysm forms, can do one or two things: either stops and never bleeds, or when it forms or shortly thereafter, because it's very weak at that time, that's when it can bleed, irrespective of the side. So I think this is, and this was the aneurysm, and again, that this was also treated with endovascular colon, because by the time he had the subarachnoid hemorrhage, he did not have any focal visual symptoms any longer. So my hypothesis, supported by others, is that the vast majority of aneurysms that bleed or that are dangerous shortly after their formation. And if you accept this theory, then all of a sudden we can explain why the vast majority of aneurysms that we find by accident are small, while the vast majority of aneurysms that present with rupture are also small. So this theory explains this apparent paradox, and at least for me, it makes a lot of sense. But that also tells us that we have to be careful, because a lot of the unruptured aneurysms that we treat probably should not be treated, and therefore, if we decide to treat an unruptured aneurysm, we have to be extremely cognizant of the risks. And again, if you accept this theory that an aneurysm is dangerous, but shortly after it forms, and then if it stays there and it doesn't, doesn't rupture, then there are reactions, connective tissue reactions, that make that aneurysm wall particularly resistant. And again, this explains the disconnect between the benign natural history of small unruptured aneurysms and the fact that most ruptured aneurysms that we see after bleed are actually very small as well. So that brings us to the importance of trying to predict, when we see a patient with an unruptured aneurysm, predict the natural history in that patient to be able to treat only those that are indeed at the risk of rupture. So we rely on the so-called natural history studies, but that's a misnomer, because if we look at the most referenced so-called natural history study, the ISHUA study, which was coordinated here at the Mayo Clinic, you see that it's not a natural history study, because yes, it is true that almost 1,700 patients did not have treatment of the aneurysm. But in the same study, 2,000 patients had open surgery and 450 had endovascular procedures. Why? Because it was not a natural history study. It was an observational study. The patient comes to me, I look at the patient, I look at the aneurysm, I say, I don't like this aneurysm, I will treat. See another patient, I say, oh, this aneurysm is never going to rupture, so we'll put in the observational cohort. So the information that we have, it's not great information, even though on a daily basis you will hear people referring to these studies. But in any case, the issue showed that for very small aneurysms, the risk of bleeding, it's very, very low. And you can see if the aneurysm is less than 7 millimeter, that risk, anterior circulation, that risk was pretty much close to zero over a fairly long period of time. But you can see that as time goes by, the number of patients that were actually followed also dropped significantly. There is no question that, and we all like magic numbers. So after ISHUA, the first study said 10, then the second study said 7, and we like this rigid cutoffs. The truth is that there is not a specific size below which an aneurysm is not dangerous, but the risk of rupture of an unruptured aneurysm, it probably linearly increases with the size. So there is really not a size cutoff, even though we like to assign, or use magic numbers. I think that now that does not mean that studies like the ISHUA did not provide us with valuable information. No, it provided with that valuable information in that at that time, mostly in the 90s, most aneurysms that the treating physician felt should not be treated had a very benign natural history, especially if they were small aneurysms. ISHUA has also showed that the risk of rupture of an aneurysm is different in relation to different locations. Posterior circulation, posterior communicating artery aneurysms have a more aggressive natural history than middle cerebral artery aneurysms or than most of the paraclinoid proximal internal carotid artery, which we found in patients with the unruptured aneurysm. Very importantly, ISHUA also showed that while certain considerations are valid for those patients who have never experienced a subarachnoid hemorrhage, those patients that have had an unruptured aneurysm diagnosed in the setting of a prior subarachnoid hemorrhage, those patients are different. In those patients, the risk of rupture of the unruptured aneurysm is higher, the so-called group 2 patients in ISHUA. You might have also, I apologize, I didn't have time to put in a slide format, but you might have also heard that the only true natural history study that we have is the Finnish study, originally presented by Seppo Juvela, and then several reiterations of that study have been published in the literature over the years. But if you look at the fine printing, you see that most of those patients, I don't remember exactly the numbers, but I think out of 116 patients, 106 had presented with the subarachnoid hemorrhage and that another aneurysm that was unruptured, which was not treated but followed over time. So when they fight about the issue and the Finnish say, yeah, but our study says completely different, they're basically fighting about the same thing because most of the patients in the Finnish study were actually group 2 patients. And if you look at the confidence interval range, they overlap with the issue. So they're basically saying the same thing, is that in a patient who has an unruptured aneurysm, but a prior subarachnoid hemorrhage from a different aneurysm, that patient has a higher risk of rupture over time than a patient who has never experienced a subarachnoid hemorrhage from another aneurysm. There was another so-called natural history study, which was the Japanese study, but the UCAS, but the study also had the same limitations of issue, is that a large number of those patients were actually eventually treated. So it was not a true natural history study. What this study really added, which is important, and has also been my observation, is that anterior communicating artery aneurysms, unlike middle cerebral artery aneurysms, they do rupture over time at a higher rate than aneurysms of similar size in other anterior circulation location. So anterior communicating artery is another location that I think has a little bit higher risk of bleeding. So This is fairly complicated and confusing. So what do we consider when we decide to treat an aneurysm? I like to schematically um, separate what I call aneurysm-related factors. Is the aneurysm symptomatic, yes or no? The size, location, the geometry, the shape of the aneurysm. Some aneurysms are nice, round, broad base, not dangerous. Some are elongated, irregular, much more dangerous. Um, Patient-related factors, of course. Some patients, I tell my patients, I said, um, we can treat the aneurysm, but we can also watch it over time. And the patient said, well, what do you recommend, doc? I said, well, your psychology is very important. I have patients that every time they have headache, they feel like they're dying. And in those patients, if I feel that the risk of treatment is very, very low, I go ahead and treat the aneurysm. Then I've had other patients that when they hear surgery or they hear a small risk of stroke, they run in the opposite direction. Those patients, if the aneurysm is fairly, I feel it's a fairly benign natural history, for those patients, I recommend no treatment. Family history is important. Somebody who has seen their mom dying of a brain aneurysm, you can talk to them about the natural history, blah, blah, blah. They don't want to hear anything. They want that aneurysm fixed. And in that situation, again, if the risk is very small, and the aneurysm is a reasonable aneurysm to treat, we would go ahead and treatment. And then, of course, if you have to keep in mind the comorbidities, somebody has cancer, a very limited life expectancy, no reason to treat a small incidental posterior communicating artery aneurysm. Risk factors is something I also look at. If a patient is an active smoker, especially with hypertension, well, that patient probably has a higher risk profile in terms of bleeding than somebody who has never smoked or who has a perfectly normal blood pressure. And then you always have to keep in mind what is the risk of treatment, which of course varies according to different operators or different places based on different degree of expertise. These same factors have been considered in over the years. There have been an attempt to provide the numeric scores to decide what to do. This is the UAT score, which was basically based on a multidisciplinary consensus among specialists across the globe. And then was followed by the FACES score, which was based on pooled analysis of different prospective aneurysm cohort. And then this recent paper showed that what we kind of suspected, if you are following somebody with an untreated aneurysm, and if you see that that aneurysm is growing, is getting larger over time, well, that patient has a higher risk of rupture than somebody else with the same aneurysm that has remained constant over the years. So aneurysm growth in those patients that are followed can be considered as a surrogate for risk of rupture. And the importance of growth over time, which actually it's not that uncommon, but also it's not extremely common. That is the concept of trying to predict growth. It's what led to the so-called ELAPSE score. The ELAPSE score, what it does, it's helpful in predicting the risk of growth over time of an unruptured intracranial aneurysm, with the idea that you are more likely to intervene in that particular patient. From a practical point of view, I would say that these scores are helpful, especially for research purposes or when we analyze our results. Do I use these scores in my daily practice? I don't really use the score itself, but I do, through my mind, I go through all the pros and cons of treating of a specific aneurysm based on all the factors that I've been discussing so far. But I don't really look specifically at the number or the score in itself to guide my recommendation. So when I looked a few years ago, just to give you an idea, you'll see that we have a large number of patients with unruptured aneurysms. The demographics are not surprising. 2/3 of aneurysms occur in female patients. The mean age is patients in the around the 60, also because the older we get, the more likely is that we are going to have imaging studies done for reasons other than the unruptured aneurysm itself. What's important here is also that the vast majority of unruptured aneurysms that we found incidentally are actually proximal internal carotid artery aneurysms. Superior apophyseal, carotid ophthalmic, ventral wall aneurysms, posterior communicating artery aneurysms, and then you see the remaining background. So this is a distribution very different than the ruptured aneurysms, where you have about, in general, 30% ACAM, 30% MCA, 30% PCAMs, and then everything else is the rest. So the proximal ICA aneurysms that we often find in these patients with unruptured aneurysms represent only 2 to 3% of the ruptured aneurysm. So again, stressing the fact that a large number of the patients that we treat with proximal carotid ophthalmic superior apophyseal artery aneurysms might probably not need treatment because the natural history of these aneurysms, especially if small, is extremely, extremely benign. So when we looked at the treatment of all these patients, as you can see over the years, the vast majority have very small aneurysms found for other reasons, so we recommend observation over time. About 1/3 have been treated nowadays, and of course, those numbers change according to a variety of things, and we will discuss the endovascular versus surgical therapy controversy. But this was about 5 years ago, our breakdown, and I think that now with the introduction of intrasaccular devices like the web, the contour, our numbers of endovascular treatments has gone up and the number of surgeries have continued to go down, which is the experience of many other centers as well. And this is a graph from a paper that is now more than 10 years old, showing that the number of clippings have gone progressively down over time in parallel with the development of endovascular techniques, while the number of endovascularly treated aneurysms has gone progressively up. So when we decide to treat an aneurysm and why we treat an aneurysm? Well, we treat an aneurysm to prevent rupture for an unruptured aneurysm, or rebleeding for an aneurysm that has presented with subarachnoid hemorrhage. Then there is a very small subset of aneurysms, especially the large ones that are at risk of growth without treatment. And when we treat an aneurysm, ideally, we should be able to prevent the rupture, prevent the growth, but do it with no complications. And then, given the choice, everybody would rather have its aneurysm treated by taking a medication, taking a pill, than by undergoing brain surgery. So naturally, I think that the natural progression is that things will become less and less invasive. But these are the goals of treatment. And so how can we achieve these three main goals? And the other thing to consider is that over time, the concept of what is a complication has changed. When I started neurosurgery in the 80s, a complication was if the patient had any motor or sensory deficit or any speech compromise. If a patient was a little bit forgetful after surgery, say, well, that's okay, that's normal. But over time, that concept has changed, and nowadays, when we look at outcome, it's a lot about cognitive outcomes, headache, cosmesis. Patients like to be, perfect, and they also like, given two choices, they like to recover quickly and go back quickly to their normal life. So the paradigm has changed in terms of what are the goals or what we consider a good outcome, and that's something that, of course, must be kept in mind. And the thing is that when you have options, while before complications were related a lot to technical factors, more and more now, complications are related to judgment errors. Maybe I should not have treated that patient. Maybe I should have done surgery instead of doing flow diversion or vice versa. So it's now that we have tools, it's uncommon that we make technical mistakes, and more commonly we make when we have a complication is because of judgment mistakes. Now, ideally, we would like to have objective criteria. And when we talk about objective criteria, okay, say, where is the evidence? Where is the scientific evidence? So if we get relaxed for a little bit and we look at the large amount of data that we have about endovascular or surgical treatment, most studies are far from ideal, but at the same time is that if we look at, for example, for ruptured anus, if we look at the evidence, and these are the three major randomized trials that have attempted to compare endovascular treatment, usually coiling in these studies, because now even the most recent one is already more than 15 years older, to coiling to clipping. What you see is that the incidence of poor outcome in the endovascular, in the surgical group, even though the studies were methodologically different, you see that the results were strikingly similar, and the studies show what we deep inside we know is that the incidence of complications, upfront complications, is especially in ruptured aneurysms that can be treated with either coiling or surgery. The incidence of complications, the incidence of poor outcome at 1 year is higher with surgery than with endovascular therapy. Now, we can discuss at And of course, treatment it should be highly individualized, depend on the individual patients. But if you have a good endovascular team and a good, equally good surgical team, you take a patient with aneurysmal subarachnoid hemorrhage, the results they tend to be slightly better with endovascular than with surgery in terms of less complications. However, what we know about endovascular treatment, particularly coiling, is that the treatment is not as complete as surgical treatment. So, especially in the patient with the ruptured aneurysm, the benefit over the years might be lost because there is a very small risk of rebleeding in patients originally treated with endovascular therapy. So the treatment choice in a patient with aneurysmal subarachnoid hemorrhage has to balance these two situations. And if you look at the literature, they all say exactly the same thing. The upfront risk, it's lower with endovascular than with surgical therapy for the most part, but endovascular surgical therapy has a higher chance of 100% aneurysm occlusion. I think that's important. That difference is important, the case of ruptured aneurysms. So even in ISAT, for example, it was suggested that a younger patient anterior circulation aneurysms, those patients, they tend to tolerate surgery better than older patients. They have a higher, longer life expectancy. So a more durable treatment might be indicated, especially in a younger patient with a small good grade aneurysm in the anterior circulation. So I think patients like this, a 21-year-old with subarachnoid hemorrhage from a small anterior communicating artery aneurysm, this patient is still nowadays better served with the surgery rather than endovascular therapy. On the other, also there are some patients with the ruptured aneurysm in the anterior circulation that have a poor geometry for endovascular, like these patients with the very regular middle cerebral artery aneurysm. In this type of patient, my opinion, surgery better than endovascular, unless the patient is in a very poor grade or is fairly elderly with a lot of comorbidities. The other thing, especially, and this is particularly true in patients with ruptured aneurysm, is that we know that after endovascular treatment, close follow-up is much more important than after a surgical clipping. So there are some patients where you could anticipate that for a variety of reasons, that patient might not be compliant with follow-up recommendation. Well, that patient maybe surgery is better than endovascular therapy, given parity of risks and so forth. On the other hand, I would say that nowadays there is little discussion that a patient like this who comes with this subarachnoid hemorrhages and basilar bifurcation aneurysm is better treated with endovascular techniques. And these aneurysm at the basilar bifurcation are actually particularly easier to be treated with endovascular than just because it's the aneurysm itself. It's in the direct. It's very easy to catheterize it. It's in direct direction of the flux. Then there are a situation, as I said, is that once you have options, if you use those, you can use those different options you have available to minimize the risk, minimize the complications, and obtain spectacular outcomes in very tricky situation. This is actually a patient from Rochester, from this town. He works at IBM, is an engineer, so fairly high cognitive level, presented with sudden headache and has a subarachnoid hemorrhage from this relatively complex anterior communicating artery aneurysm. So remember, this patient is an engineer. The aneurysm is fairly large, and we know that coiling is not an ideal treatment, but despite that, we decided to go ahead with partial coiling of this aneurysm just to protect the patient from the immediate risk of subarachnoid hemorrhage. And since you can see here that the ipsilateral A1-2 junction is in the it's in the same axis, this patient was treated with delayed flow diversion with a beautiful anatomical result. But more importantly, look at the flare MRI of a patient with this aneurysm who had the subarachnoid hemorrhage absolutely pristine, just a little bit of change right immediately around the aneurysm. This person was able to go back to work after 3 months in the same capacity, and only recently, you can see we did in 2012, only 3 or 4 years ago, he went on to retire. Now, while I think that there is still a role, important role for surgery in ruptured aneurysms, especially anterior circulation, for unruptured aneurysms, nowadays it's uncommon that we do surgery for an unruptured aneurysm. Well, I will show you why. Again, if we look, there is this recent trial that tried to, in a randomized fashion, compare surgery to endovascular for untreated aneurysms. But guess what? The conclusion was all what we know already. You can see enrollment was very slow in this trial. The primary endpoint was residual aneurysm or intracranial hemorrhage at 1 year. And as you expect, the incidence of residual aneurysm is going to be much higher with endovascular rather with surgery. There were really intracranial hemorrhage at 1 year were actually more common with surgery than with endovascular, but were so rare that really didn't push the balance. It was the issue of the residual aneurysm, but we knew that. We knew that with endovascular, you end up with the more higher incidence of residual aneurysms, but lower complication rate. If we look at the major complication rate, not much different between the two, but when you start looking at new neurological deficit, length of stay, as you would expect, higher with surgery than with endovascular therapy. So same thing that the randomized trial told us for ruptured aneurysms, except that in unruptured aneurysm, does it really, a little bit of residual, does it really make a difference? These aneurysms, after treatment, if there is a little bit of residual neck, we know now they don't bleed. So does it really? I think we should try to accept the fact that for an unruptured aneurysm, 100% a perfect picture might not necessarily be that important in preventing that aneurysm from bleeding at times. Now, nevertheless, there are situations like we still do surgery. This is a very young person, family history, very small internal carotid artery aneurysm. She doesn't want to hear about observation or anything. No need to do endovascular acrobatics for that this aneurysm. This is actually not even that straightforward because so small to clip, but that's what we decided to do because we didn't feel that there was any need to do endovascular complex solution in these patients. You still occasionally have patients with a fairly complex geometry, like this patient with an anterior communicating artery aneurysm, small, broad base, irregular. And you can see that this is actually one of those rare aneurysms where a perforator actually was emanating from the base of the sac, not from from the parent artery itself. So at the end, this is an aneurysm that nowadays you can expose circumferentially, identify all the vessels, and successfully clip. Another thing is that surgery has improved because less use of retraction, less manipulation, and the fact that we have available ICG fluorescent has been very critical in decreasing the incidence of important complications, because a lot of our surgical complications were related to perforator injury. But you can see now with the ICG fluorescent, you can get a beautiful view of all perforating vessels. So, as I said, I think we need to move away, especially for unruptured aneurysm. For ruptured aneurysm is still important, but for unruptured aneurysm, this is a patient that we treated, one of our early web cases. I see Dr. Checker on the line. He'll probably we laugh because in the United States we have had the web available only starting in 2019, and Turkey and in Europe has been available for many more years. But in any case, this was one of our early web cases in 2019. This is the follow-up almost 3 years later, and is this after 3 years? Is this plump neck really that important? This patient is doing great. The aneurysm, for all practical purposes, I think has been taken care of. The risk of rupture has been eliminated. So I think we need to look for the unruptured aneurysm after any type of treatment. The endpoint should be rupture over time, rupture or aneurysm growth, and rather than keep fighting on the 1 or 2% residual, because in doing so, I feel that we are only playing the game of the industry, because they like to push gadgets that have ideally 100% rate of occlusion. And credit to my friend, Dr. Checker, because he really was one of the first ones to stress the fact that you need to look at what he calls the aneurysm remodeling. If after the treatment, like for with flow diversion, the aneurysm is decreasing in size, but there is a little bit of a bump, does that really matter? Probably not, because the aneurysm, the wall has collapsed. The wall of the aneurysm has become much thicker, and what you see, it's a very small residual that most likely has no clinical significance in unruptured aneurysms. The ruptured aneurysms are different. So we talked about this breakdown, and by the same token, I think that nowadays, when we are dealing with the small or medium-sized paraclinoid aneurysm, there is really no discussion. Flow diversion is definitely a treatment of choice. Really, no need to do surgery for small or medium-sized paraclinoid aneurysm. Now, giant aneurysms, it's still a field where I think we need to carefully evaluate all possible available alternatives, because even with modern endovascular tools, the results of endovascular therapy alone for giant aneurysms are not what I would consider ideal. So when we think about the treatment, always you hear clip or endovascular, and the truth is that I think that with intelligent utilization of the tools that we have available, as we proposed in this article in Journal Neurosurgery more than 15 years ago, you can really treat the vast majority of the aneurysms that we see. And I think that if we are able to do that, if we exclude the dolichoectatic vertebrobasilar and the giant aneurysms, I think in 2023 we are very close to that ideal goal of zero morbidity and mortality for the treatment of aneurysm. And the way to do it is really what I define as intelligent use of all possible available options. And once again, I'll thank you for the kind invitations. I had originally intended to show, especially for the neurosurgery residents and trainees, some videos summarizing some of the basic principles, but maybe that could be the topic of a different conference. The topic is so broad that then I didn't have additional time, and among other things, my clinic is starting in a few minutes as well. So thank you very much.
Thank you.
Thank you. With your permission, I would like to interrupt. Now we will ask a question. I will paste the URL address of the Google Forms where the question has been written and will be answered in the chat here. And the question is for medical students and neurosurgery residents. Professor Lanzino will autograph and give the book Cavernous Malformations of the Brain and Spinal Cord to the first medical student who answers correctly. It is not over. Professor Lanzino will also autograph and give the book Cavernous Malformations of the Brain and Spinal Cord to the neurosurgery resident who gives the first correct answer. So Professor Lanzino will give 2 books in total. At the end of the question and answer section, we will announce the correct answer and to the question and the winners. Good luck, everybody. Okay, I finished now.
Okay. Thank you very much, dear Hassan, for this offer, and dear Professor Lanzino, for your book that will be offered to the students. And thank you for your all-round analysis of the aneurysms. It's the hard topic. We know that every decision can mean somebody's life and health. And looking forward, we have many questions here. I will start from the question from Madonna Ahobadze from Georgia. Thank you, Dr. Lanzino, for your spectacular lecture, for your dedication to teaching, and for going above and beyond to create a valuable learning experience. Your expertise and passion for aneurysm surgery were evident in your ability to convey complex concepts in a clear and engaging manner. So grazie mille. I have 2 questions. With the increasing emphasis on personalized medicine, how do you see the role of genetics and advanced imaging techniques in predicting aneurysm rupture risk and tailoring treatment plans for individual patients? And please answer the question. I will ask second question.
Sure. That's a very, very important question, because I think that will be the future. I hope that one day we will be able to identify individual genetic tracks that will allow us to predict the risk of rupture, but I suspect that's probably a little bit far away. I had a lot of enthusiasm myself because I felt that the answer to predict which aneurysm is safe to watch and which one should be treated would have come from advanced imaging. And I'm sure that at some point we'll be able to get a better definition of the aneurysm wall, the aneurysm environment, and be able also to integrate information about flow dynamics. I had a lot of enthusiasm about the utilization of vessel wall imaging on MRI, but I must say that my experience in utilizing it every day in clinical practice to follow unruptured aneurysms has not been quite as good as some of the papers that I think they are done, the studies that are done for research purposes might suggest. But there is no question that the future is that to be able to identify a scoring system for the individual patient based on the factors we discussed, but also more advanced imaging and some underlying genetic factors. And for that matter, I also think that at some point we'll have a medication available to take that in a patient with an unruptured aneurysm will reinforce the wall, preventing rupture.
Thank you, Professor. And the second question from Madonna is for young neurosurgeons like myself, what advice would you offer when it comes to both staying updated with the latest developments in aneurysm management and refining our surgical or endovascular skills in this specialized field?
So my advice is that I think this is a great time to be a young neurosurgeon interested in this field because the resources available today are so incredible that I think only people like myself and some of the colleagues on the audience can appreciate. If we think in the late 80s, we had no access to Dr. Roton lectures unless you had the luxury of going to Gainesville and spending months there. Nowadays, that's available to anybody on your computer. If we wanted to see Yasargil operating, it was incredibly difficult just to arrange for a week or two. Then you go there. If you're lucky, you see 5, 7 operations in 2 weeks. Nowadays, you have Ernest Niemi 1001 videos available and many other videos, many master collections. So my advice is to use as much as you can all the resources available, online lectures, online videos, anatomical courses are available throughout the world. It was not the same case when we were going through our training. Same thing for microneurosurgical or lab or endovascular simulation. It's really quite advanced. Microsurgical simulation is not quite there, but is advancing rapidly. So that's my advice, is that it's true that the number of cases available for open endovascular surgery might be becoming less and less, but it's also true that the resources available nowadays are so widespread, immediately available, that I think the new generation of endovascular and open surgical surgeons have really the chance to become great and surpass our current generation.
Thank you very much. I agree with open surgery will be required in the medicine long years, and we need people who will be dual expertise on this field. Next question from Aydin Yunus. Thanks for your Giorgio's presentation in ruptured cases. The advantage of cleaning the some blood, opening the cisterns, doing the sympathectomy, etc. with surgery. Will these all might cause more benefit for the patients over head endo treatment?
Yeah, that's it's always, it's been debated, especially at the beginning when endovascular techniques were more applied. We were debating, well, but at surgery you can get a better chance to clean some of the blood in the cistern and open the lamina terminalis. The truth is that it's you can do all of those things, but do they really translate into a benefit for the patient? Probably not. Also, surgery by nature of surgery, especially in a patient with an acute subarachnoid hemorrhage, it implies an additional manipulation, which might in turn take away potential benefits of some of the things that you have mentioned.
Thank you very much. And the next question for the same doctor. In surgery, it's not uncommon to find accessory aneurysm which could not before surgery on DSA. Can we discuss with the patients in favor of surgery over endo?
I think that nowadays depends on I think it depends also a little bit on what you have available nowadays. If you have available the ability of doing 3D reconstructions, it's less and less common that we might come across aneurysms that are not seen on catheter angiogram. And, for a ruptured aneurysm, you treat the dangerous aneurysm, the aneurysm that has ruptured. So the absolute value of treating very small accessory aneurysms that are so small that you might miss on a regular angiogram, I'm not sure it's one such a benefit that it's something I would discuss. I would bring up with patient as a potential benefit of surgery over endovascular.
Yeah, thank you. I can remind the one case of very aneurysm rupture during dissection. It was not found on DSA, so it could be even harmful in some cases. The next question from Saruhan. Hi, Giuseppe. This is Saru. Don't you think we also need to look at residual aneurysm in a different way after the impact of flow modification? This is why we come with a new classification for aneurysm, OCC, adding stable flow remodeling. Do we treat picture or patients?
Yes, no, I agree that, as I said, I think there is a fundamental difference between ruptured aneurysms and unruptured aneurysms. In ruptured aneurysms, yes, there is no question that if you are able to completely obliterate the aneurysm, it's better than an incomplete treatment long term. It also reduced the need for close follow-up and the need for further treatment. For unruptured aneurysms, I perfectly agree with Dr. Chekiger. I think that if you are able to remodel the flow, if you do take away most likely the risk of the aneurysm rupturing or growing, and therefore we must do our studies with the endpoint of aneurysm rupture and not so much a degree of filling. And as I mentioned before, Dr. Checker and this group were some of the pioneers within this concept, proposing newer grading systems to assess for aneurysm remodeling. So for ruptured aneurysms, I definitely agree.
Thank you for the answer. And one more question from Yugur R. Has two parts. The second part of the question is answered, as noticed, the doctor who asked the question, but the practice of endovascular treatment has gradually increased. What is the point we have reached today?
Well, I think that it varies a little bit according to different type of expertise and different device and materials available. I think that when it comes to aneurysm surgery, I always say that when it comes to unruptured aneurysms, we can treat, probably the vast majority of unruptured anus with endovascular techniques safely. And again, if the endpoint is prevention of rupture, I would think effectively. For the ruptured aneurysm, as I said before, there is still an important role for surgery in many different situations, especially in the anterior circulation. And then paradoxically, for the giant aneurysms, that's a type of aneurysm where I'm going a little bit backward and realizing then there are situations where surgery with or without bypass, it can be even a better strategy because the results of endovascular for truly giant aneurysms are not quite as good as they should be.
Thank you. I want to ask one question. You mentioned that aneurysms too small to clip. So, in your experience, what is the cutoff size of aneurysm too small to be safely clipped?
Well, definitely a very small aneurysm is incredibly challenging to treat with the endovascular. But some of these very small aneurysms can be challenging to clip with surgery because we can use different techniques, but the clip tends to slip, or worse, you can avulse the entire attachment of the aneurysm. I don't think there is a cutoff, but definitely some of those small aneurysms, Yasargil has showed a long time ago that sometimes with the low power cautery, you can gently with bipolar coagulate and lead to flattening of the wall of the aneurysm. And so definitely there are those microaneurysms that quite often you see in these patients adjacent to the aneurysm that you are treating. Those might be treated with alternative techniques than clipping, but even that low power bipolar does require quite a bit of experience to know how to do it and when to do it. You can do it safely.
Thank you. And what is your opinion about the wrapping of aneurysm if it's not fit for clipping? Do you use?
I have used it, not so much as a primary, but especially when sometimes you are forced after clipping to leave a small residual neck to avoid compromise of the parent artery, especially if there is a calcification or adenoma at the level of the neck. I think that there is some evidence that wrapping might not protect the patient in the immediate phase, but after 2 or 3 weeks, as you start having some degree of foreign body reaction and inflammation, it might probably provide some extra protection by, increasing the thickness of the wall or the thickness of the perianeurysmal environment.
Thank you very much for answers. I see no more answers in the chat. I see some thanks from you, Gur. It was an excellent presentation. Thanks a lot. From you, Roland Kosmane. Thank you, Professor Lanzino. It was a great lecture. And Dr. Uday Gupta from India. Thank you, Professor Lanzino. It was a wonderful seminar. We learned a lot today. Best regards. So if somebody have the question from audience, Hassan.
Yeah, now it's time to announce the winners. Let me share my screen so everyone can see that there is no match fixing. Okay, and
so who
now I will share my screen. We asked that the ELAPSE score was created to predict the risk of aneurysm rupture, predict the risk of aneurysm growth, predict the risk of endovascular treatment, predict the risk of surgical treatment, to predict the risk of aneurysm recurrence after treatment. Can you see my screen?
Yes, we can see your screen.
And what was the right answer, Lanzino, Professor Lanzino?
The correct answer is B. The ELAPSE score was created to predict the risk of aneurysm growth.
Thank you. And now check the answers. As we can see, okay, let's summary. There are 15 answers, mostly from Turkey, also from Azerbaijan, Georgia, Germany, Italy, Kazakhstan, Germany again. And most of them are medical students, 73%, and 26% is neurosurgery residents. And now the first answer comes from Nerdanyan from Germany, neurosurgery resident, and he gives the right answer, yes. And this is the neurosurgery resident, first winner, and then we continue to the second answer. Comes from Burak Acar from Turkey, medical student, but he gives the wrong answer. Then we go to the third answer. So Ayman, Kazakhstan, neurosurgery resident. She gives the right answer, but she is the second one as a neurosurgery resident, unfortunately. Yesterday she won, but today she was late a little bit. And the fourth answer comes from Kenan Kerem Özçınar. He is a medical student, and he gives the right answer. So Kenan Kerem Özçınar and Nardanyan. These are the winners. And Nerdanyan or Nardanyan?
Nerdanyan.
Nerdanyan. You are the first winner.
Azan, if you can send me the address of the winners, I'll be happy to send the books. I apologize, I have to run. My clinic was supposed to start at 1. So, but this was great, was a pleasure. And I think we can do another one for the approaches to different type of aneurysms.
Yeah, it will be perfect. And I hope you have some other books.
Okay. All right. Great.
Okay.
Thank you so much. Bye.
Thank you very much.
Thank you so much. Okay. Kenan, you can turn on your microphone. Yeah.
Merhaba hocam.
Merhaba. Kazandın. Tebrik ederim. Ben
Teşekkür ederim.
Şeyin adresini vereceğim. Hocanın adresini, e-mail adresini sana. Sen ona e-mail yazarsın. Ve kargoyla göndermesini istersin. Sorry, I speak Turkish.
I understand everything.
Sometimes I forget because Kenan is Turkish. student. So I thank everyone.
Congratulations.
It was a great lecture and great day. I want to thank everyone who joined us today. Thank you.
Thank you very much. Thank you.
Bye-bye.